Well, good morning, good afternoon, good evening, depending on where you are. We are on the hour right now, but we are going to have a couple more minutes of waiting for some of our latecomers to join. So just sit tight and we will start maybe in a couple of minutes. Thank you. Hello again. We are waiting one more minute before we start. Thank you for your patience. Okay, I think we are good to go. So again, good day, everyone. My name is Daniel Rodriguez. I am a professor of city and regional planning at the University of California at Berkeley. And I am delighted to be your moderator today on this presentation on air pollution and health in Latin American cities. We are very excited to have a diverse group of attendees today with us. Really spanning the entire globe. You can see here that you come from not only the Americas, but also Europe, Africa, Asia. We also have a very diverse group of individuals representing different professions, with participants coming not just from academia and research, but also we have students, we have others that are coming from the private sector, nonprofit organizations, advocacy groups, and government, among many others. So great diversity, which is exactly what we need to understand and tackle the issues of air pollution and health. So before we delve into the webinar presenters, I want to summarize the context of this project, SALURBAL. SALURBAL stands for Salud Urbana en América Latina, Urban Health in Latin America. It is a 5-year project launched in 2017. It's led by Drexel University's Dornsiff School of Public Health with partners throughout Latin America and the US. And we all work together to study how urban environments and urban policies impact the health of city residents throughout Latin America. One of the key areas of research with SALURBAL is to consider how urban policies that influence the built and natural environments, for example, urban patterns or transportation policies, or even intermediate outcomes like air quality, affect the urban health outcomes and disparities in those outcomes for both children and adults. So the aim is to think and identify attributes that we may not readily identify with health outcomes, and consider ways in which city actors can influence them to improve conditions. An aspect that makes this research particularly important is that some of the urban attributes and policies that we are considering are also very well aligned with achieving other environmental and social outcomes of interest. for example, the reductions in greenhouse gas emissions or improvements in social equity. So it's kind of a win-win in many cases, these important co-benefits. So in this way, the work that you'll hear today is one step forward in understanding how these policies in this particular Latin American context contribute to improving planetary health. To do this over the last 3 years, the SALURBA'Ls team has compiled a large data set, including data that describes the built and physical environments of cities. We have compiled data for 371 cities across 11 countries. And that data include transportation options available, how much traffic delay people face and experience in each city, some land use characteristics, shape of urban patterns, air pollution data, and other health outcomes. We're going to be focusing, of course, on the urban patterns and air pollution and some mortality outcomes today. We have linked all this data at different geographical units, what we call subcities, which are small areas shown here in the image, and also for the city as a whole, kind of the urban footprint, and beyond that, the administrative unit of the city. So geography varies sometimes as we think about this phenomena in space. Without any further delay, I know you're anxious to hear from our speakers. I want to introduce our main participants today. They'll give 10-minute presentations, and then we'll have ample time, more than 30 minutes, for questions and answers. So let me start with our first speaker here on the left of your screen, Dr. Nelson Gouveia. He's a professor at the Department of Preventive Medicine at University of Sao Paulo Medical School, where he teaches environmental epidemiology and conducts research on environmental exposures, such as air pollution and their impacts on health. In the middle here, you see Dr. Ana Ortigoza. Ana is a postdoctoral research fellow at Drexel University in the Urban Health Collaborative. She is a pediatrician, so she's a medical doctor, and also an epidemiologist, and conducts research on the urban determinants of health and health disparities among women, children, and youth. And we end with Dr. Josiah Kephart, who is a postdoctoral research fellow at Drexel Urban Health Collaborative. He is an environmental epidemiologist who conducts research that supports the development of environmental interventions to reduce chronic disease and promote health equity. So to end, let's turn briefly to logistics for the next hour or so. We will reserve time for Q&A after all the presentations. However, feel free to send your questions anytime using the chat feature. I will be reading out the questions after all the presentations so that our panelists can respond accordingly. So without any further delay, I am going to go ahead and stop sharing my screen and ask Nelson to begin his presentation. Thank you, everyone, and welcome again.
Hi, sorry, thank you, Daniel, and now I can say, yeah. Hello, everyone. Thank you for this, and I'm Nelson Gouveia from the University of Sao Paulo, as Daniel mentioned, and I'm gonna present these results from this study I've been doing under the SALURBA'Ls project, which is on air pollution levels in Latin American cities. I'm talking a bit about population exposure, inequalities in these exposures, and identifying some associated city characteristics or even factors that might be related to these air pollution levels. Well, first, when you talk about air pollution, we need to remember that we are talking about contamination of air by a mixture of solid particles and gases. One important type of air pollution, which is going to be the focus of this presentation, is PM, or particulate matter, which can have various sizes and diameter. The most dangerous one to our health is PM 2.5, which are particles smaller than 2.5 micrometers in width, because this can go very deep into our lungs when we breathe in. Air pollutants in general, and particulate matter in special, can be originated from several sources. Natural sources such as volcano eruptions or the Sahara dust, but mostly by man-made sources, like burning of biomass, like forest fires, or burning of fossil fuels in industrial process, home heating, and in transport. In fact, transport or traffic is the main source of air pollution for most urban areas all over the world. Once they go very deep into our lungs, these particles can reach our bloodstream and then affect many organ systems like our liver, heart, lungs, skin, the reproductive system, our brains, eyes, throat. That is, besides respiratory diseases, breathing air pollution is also associated with several other diseases such as heart disease, stroke, dementia, low birth weight, and many other effects. That is why the World Health Organization, WHO, recommends that air pollution levels be maintained below a certain threshold to prevent these negative health outcomes. WHO recommends threshold levels for several pollutants, but we're going to focus here on PM2.5. And for WHO, the threshold for PM2.5 as an annual mean is 10 micrograms of particles per cubic meter of air. That's the threshold for PM2.5. The World Health Organization also estimates that 9 out of 10 people in the world are exposed to unhealthy levels of air pollution, with an estimated 4.2 million deaths attributable to this air pollution every year. For Latin America, previous estimates indicate that over 110 million people in Latin America are exposed to these unhealthy levels of air pollution, with associated 58,000 deaths every year. However, these estimates for Latin America are based only on a small fraction of cities that have equipped monitoring networks to measure the air quality, to measure air pollution. In fact, these are based on only over 100 cities that have network monitoring stations. Thus, the purpose of this SALURBA'Ls study was to examine what are the current levels of air pollution in Latin American cities, if these levels of air pollution are complying with WHO's air quality guidelines, and also to identify some city characteristics that might be linked to these air pollution levels. To do so, we use air pollution information derived from satellite readings for the year 2015 that cover all Latin America. In gray here on this map, you can see all the countries which are part of the SALURBA'Ls project. And in red, we have all the cities over 100,000 inhabitants that we are studying. So we collect information for all the cities, and for each one, we have the satellite readings that provide all these blue dots are a satellite reading by 1 kilometer square area. So then we average this satellite readings. This is an example for the city of São Paulo, where I live. So we can average these readings for geographic limits of a city, and then define the annual mean of PM2.5, in this case here, for the city of São Paulo. And that's what we've done for all the cities in SALURBA'Ls. Then we have this information that provides this graph that shows the levels of air pollution of PM2.5 in all 1,425 subcities in Latin America. Each dot here represents a subcity. And you can see that this air pollution varies greatly across different cities within each country. That takes the example of Peru, where you have cities with air pollution mean annual PM2.5 of around 5-6 micrograms per cubic meter, while other cities have levels well above 45 micrograms per cubic meter as annual mean. There's a huge variation within one country. And we have also a large variation across countries. See how Chile stands out here in terms of other countries. And this is the dashed red line is the 10 micrograms per cubic meter, the WHO guideline. So then we can see that almost 40% of cities and 55% of sub-cities in Latin America are experiencing air pollution above their quality guideline. In summary, 38% of cities and 55% of sub-cities, which represent around 171 million people in total exposed to unhealthy levels of air pollution in the region. Among these 171 million, we have 12.3 million children under the age of 5 years old and 14 million adults over the age of 65, which are the two age groups which are more susceptible to suffer the health impacts of this bad air. And as we noted in the previous figure, in the previous graph, there are large disparities among countries, with the proportion of the population exposed to unhealthy levels of air pollution going from as low as 10% in Central American countries to as high as 86% in Chile. That is, 86% of the population and urban population in Chilean cities are possibly exposed to this unhealthy air pollution. In addition, we found no difference in exposure by gender. That is, men and women are equally exposed in Latin America. We found also no difference in exposure by socioeconomic status. The rich and the poor are equally exposed in Latin America. But in terms of age, we found that in Argentina, Brazil, Chile, Mexico, and Peru, the elderly population are slightly more exposed to these unhealthy levels of air pollution. While in Colombia and Central American countries, the younger population is more exposed. In terms of the city characteristics that drives air pollution levels in Latin America, we found that larger cities, those with larger populations, cities with a higher per capita gross domestic product, the GDP, that is, richer cities in general. Those with a higher motorization rate, is the number of vehicles per population. Those with a higher traffic congestions, traffic delays, and those with higher street intersection density, which is a measure of connectivity in the street design. All these characteristics are related to higher air pollution levels. On the other hand, cities with higher population density, that is, more compact and dense cities, those that have more green space, and those where we have the presence of mass transit infrastructure, such as metro, subways, or BRT, the bus rapid transit. These characteristics are associated with lower levels of air pollution. This means that air pollution levels in Latin America were associated with distinct built environment features, which are in fact amenable to policy interventions that can provide safer clean air for the population. For example, cities can implement actions such as increasing the amount of green spaces, controlling traffic congestions by making road traffic more agile, and encouraging the use of mass transit or other sustainable transportation systems like bikes. So all these measures can reduce current levels of air pollution in Latin American cities. That is, increasing our knowledge about drivers of air pollution in urban areas will help us devise interventions towards creation of healthy urban environments that will promote better quality of life for all urban residents. So that is it. Thank you very much.
Thank you, Nelson. Terrific, very stimulating presentation. To the audience, I remind you, please jot down your questions. You can send them through the question and answer feature to the group so that we can answer them at the end and address them. So our next presenter is Dr. Ortigoza.
Thank you, Daniel. Are you seeing my screen, right? Thank you also to the audience that is joining us today. I'm going to present some results of a study we carry out looking at the effect of ambient air pollution on under 5 infant and child mortality in Latin American cities. I think it's important to begin thinking, why is this important to consider the impacts of air pollution in this population in Latin America? Well, first, because almost 10% of the population in Latin America is under 5 years of age. And more than 80% of Latin Americans live in cities, where also air pollution levels are one of the highest in the world. And even when there are studies on the impacts of air pollution on many health outcomes among infants and children in other parts of the world, in Latin America, the evidence so far, it's limited to the few of the greatest or largest cities in Brazil, Mexico, and Chile, which also happens to be the most polluted cities. And in this case, what we are going to show is results from an analysis where we included a wide size range of cities of more than 100,000 inhabitants. And that represents small, medium size, as well as the big metropolitan areas, some of the biggest cities in the world. Which also implies the inclusion of varying levels of ambient air pollution, and to see how these different levels of air pollution are associated with infant and child mortality. Why it's important to study, but particularly focusing on children, because infants and children have physiological characteristics that make them especially vulnerable or susceptible to the effects of air pollution exposure. There are many tissues and also body systems that are not fully developed by the time of birth. And for example, lungs, as Nelson was explaining, have greater permeability to toxic agents. And also liver and kidneys have also reduced capacity to detoxify and excrete these harmful substances once they get into the bloodstream. And in addition to these characteristics, also infants and children are more likely to breathe through their mouth, and also have higher ventilation rates and spend more time outdoors compared to adults, which also increases their exposure to air pollutants. So in this particular study, we aim to understand firstly, whether increases in ambient air pollution over time were linked to changes in mortality among under 5 population. For answering this question, we implemented a longitudinal approach that I'm going to briefly explain later that allows us to make stronger inferences about the relationship between air pollution and mortality in terms of causal inference. And once we determined this association among the whole under 5 population, we then did or pursue a separately analysis looking or focusing on infants first, which means the population from 0 to 1 years of age, and then also looking at or applying the same analytical strategy to children, which are by definition the population between 1 and 4 years of age. And at the end of this presentation, we finally would like to make a brief comment or discussion about how these results that I'm going to show have potential implications for actions taken at or the relevance of actions that also Nelson was mentioning before at the local level, and also to support national or global actions related to environmental protection policies. Technically speaking, this study was carried out including almost 1,150 sub-city units that were part of 337 cities in 7 Latin American countries. These are Argentina, Brazil, Chile, Costa Rica, Colombia, Guatemala, and Mexico. In each of these units, we collected data over the 2010-2015 period. We collected yearly measures of air pollution and also mortality rates. Air pollution data correspond to what Nelson was mentioning before, the annual average of PM 2.5 made by satellite measures, satellite readings, and then annual under 5 infant and child mortality rates were retrieved from vital statistic registries and population data and projections that were linked to these units by either the deceased place of residence or maternal place of residence in case of live birth. And again, we took first under 5 mortality rates as our main outcome. And then we also did the same kind of analysis considering infant mortality and child mortality rates as 2 different outcomes. To graphically explain a little bit the longitudinal approach, what we were trying to understand, or we aimed with this analysis, is to see that over time, how increases in each unit of PM2.5 was linked to changes in mortality rate. Our main findings here, you can see, very technically speaking, that each increase of 1 microgram per cubic meter of PM2.5 was linked to either 0.3% and 0.4% increase in under 5 mortality and infant mortality rates, respectively. We haven't found any association of changes in air pollution linked to changes in child mortality, but overall, on average, air pollution levels or higher levels of PM2.5 were associated with both higher infant and child mortality. To understand the magnitude of these results and how this can be translated to a more approachable way of understanding this, this is the same to say that these cities in our sample, as Nelson was showing in previous presentation, cities with the lowest levels of air pollution in our sample became similar to those, let's say, in the highest or the 5% highest levels of air pollution. We will observe that under 5 mortality will increase in 6%, by 6%, and infant mortality will increase in 8%. This is the same to say that they will, these changes in the levels of air pollution will be producing around 9 additional deaths per 1,000 live births with respect to the mean under 5 mortality rate that we got in the sample, and almost 11 additional deaths per 1,000 live births with respect to the mean infant mortality rate that we had in our sample. These associations are strong because we were able to capture how changes in levels of air pollution are linked to changes in mortality under 5 or infant mortality over time. And this is also important in terms of causal inference because we are somehow explaining that changes in mortality are explained by changes in the levels of air pollution. And also these are strong evidence because we were able during our analysis to account for other characteristics of cities that are linked either to levels of air pollution or to mortality, as we have shown in previous webinars. And so even when we control for these characteristics, air pollution, increasing levels of air pollution have an independent effect on mortality among under 5 and infant population. So in summary, we found in this study that increases in the levels of air pollution in cities are related to increases in mortality among under 5 population. And these findings are in magnitude and direction similar to other findings or other studies carried out in other parts of the global south, like in Central and West Africa, carried out by Wiley et al., and in Asia by BM et al., that they were also able to show how different sources of PM2.5 were associated with increasing levels of under 5 mortality rates in certain administrative units. So far, we think this, to our knowledge, this is the first study in Latin America to examine these associations between PM2.5 concentrations and under 5 mortality in across a wide range of cities and administrative units in 7 countries of the region. We also found that in our study, the association between changes in PM 2.5 and overall under 5 mortality were also mostly driven by mortality among infants, which also support this idea that there is greater vulnerability at younger ages, where body systems are even less developed. We also consider that in utero PM 2.5 exposure has been linked to prematurity and low birth weight, and which is also a risk factor of infant mortality. And given that we in our analysis, we relied on annual averages, it is possible that at least some of the impact that we've seen in our study that we observe on infant mortality could be linked to also prenatal exposures of PM 2.5. And finally, we think that this investigation of the impact of ambient levels of air pollution on health is directly policy relevant, given the implications that it has for advocacy of regulation of ambient levels and regulations on environmental protection. As Nelson was mentioned, there are many urban interventions that can mitigate or reduce the impact of air pollution in cities, and this also along with environmental protections and air quality policies are key to reduce amenable death among infants and children. Finally, just to mention that besides that these evidence are supporting how to improve population health at early stages of life, any evidence of the impact of air pollution is also an advocacy or a claim for many other sustainable development goals, such as the need of affordable and clean energy to combat the consequences of climate change and the promotion of sustainable cities and communities. So thank you for listening. And I think I'm turning to Josiah or to Daniel, I don't know.
We go to Dr. Kephart. Thank you, Dr. Ortigoza, for staying on time. And Dr. Kephart?
Hello, everyone. So I'm Josiah Kephart. I'm a postdoctoral fellow within the SALURBA'Ls project. And today I'm going to talk a little bit about COVID and the impact of the COVID-19 pandemic on air pollution within these cities in Latin America. So Latin America is truly one of the global epicenters, if not the global epicenter of the COVID-19 pandemic. You can see here on this map on the right, this is the share of the population who so far in the pandemic over the last 6 months have had a confirmed COVID-19 case. And as you can see, really within the Western Hemisphere, North America, Central America, South America, there's some of the highest rates of cases within the world. And in fact, if you look at the top 20 countries across the world, in terms of what proportion of the population has had a confirmed COVID-19 case, Latin America and the Caribbean countries make up 7 of those top 20. And if you only look at cases within the last 7 days, so this is where the pandemic is most active at this moment, 10 of the top 20 countries are in Latin America and the Caribbean. So similar to the US, to Europe, to many, many parts of the world, within Latin America, many countries and cities have implemented these lockdowns or stay-at-home orders or other sorts of closing schools, other sorts of policies to try to restrict movement and reduce COVID-19 transmission, reduce transmission of the novel coronavirus. And within this analysis, I'm going to focus on these 4 cities here that you can see on the right: Mexico City, Lima, Santiago, Sao Paulo. These are some of the largest mega cities within the region. And these lockdown orders have had a predictable impact on traffic congestion within these cities. So on this plot here on the right, this is comparing the amount of traffic congestion in early March before any lockdown orders with the end of March going into April. And as you can see, traffic has been reduced in all 4 of these cities by about 80% and stayed constant. Traffic is still actually reduced even now in many of these places. So as mentioned by Nelson and Anna, you would expect that traffic is very related to urban air pollution levels, and that a reduction in traffic might have an impact on urban air pollution levels. So one easy way to do that is to look at the urban air pollution levels via satellite. So what you're looking at here is for each of these 4 cities, Lima, Mexico City, Santiago, Sao Paulo. On the left panel here is a satellite quantification or estimate of tropospheric NO2, which is just a common marker of the amount of air pollution that's sort of coming up from the city into the lower part of the atmosphere. In the left panel, you can see the first 10 days of March. The right panel, you can see the last 10 days of March. And if you look at the top left here, for example, in Lima, you can see this red. This red means lots of air pollution. White means less air pollution. This major reduction before the lockdowns and after the lockdowns. If you look over at Mexico City, Santiago, Sao Paulo, you can also see some changes in those urban air pollution concentrations. Usually, in most places, a reduction, which is sort of going from red to white here in this situation. But satellite imagery is not necessarily, or measuring air pollution concentrations in the atmosphere is not necessarily what people are breathing on the ground. And so what we did here in this analysis, in the first part of this analysis, is we looked at data from government air monitor networks in these 4 cities. So each of these cities has different air monitors placed around the city that record PM 2.5 concentrations every hour. And again, PM 2.5 is this major air pollutant, which was the focus of Nelson and Anna's presentations. And so what we did here is the gray bar here is the first week of school closures in each city. You can see that that timeline doesn't perfectly line up in each city, as you would expect, because they're all making their own decisions. And on the x-axis here is the beginning of March. It goes from the beginning of March over to the end of March through April. And what we did is we compared PM 2.5 concentrations in these cities in 2020 compared to the 3 years prior, 2017 to 2019. And you can see here in Lima, you can see what turns out to be about a 41% reduction in citywide PM 2.5 concentrations compared to the 3 years prior. In Santiago, it's about a 21% reduction. Sao Paulo, 31%. Mexico City, just a very small change, about a 5% reduction. And again, this is comparing air pollution levels during this first week of school closures during the COVID-19 lockdown compared to the same time 3 years prior. And as Nelson mentioned earlier, the World Health Organization guideline here is 10 micrograms per cubic meter here, this blue line. And you can see that these reductions are really get some of these cities much closer to this guideline, right? So this is a meaningful reduction in concentrations. So why does this matter, right? This is kind of predictable. You would expect that traffic going down would relate to air pollution levels being reduced, right? Well, with urban air pollution, there's really this pervasive pessimism about reducing ambient air pollution. A lot of statements, well, there's nothing we can do about the geography, there's nothing we can do about the climate. These are sort of these fixed factors that we can't really do anything about. But the reality is what we've seen here is that during these COVID-19 lockdowns, the air is actually noticeably cleaner. People are actually walking outside and experiencing this cleaner air. And these lockdowns were not even intended to reduce air pollution, right? They're intended to reduce the transmission of the pandemic. And so you don't need a full economic shutdown to see these reductions. What you need are targeted policies that reduce air pollution at the source while prioritizing equity and limiting the economic cost. So this shows some evidence that reductions are in fact possible. In fact, they actually happen sort of as a secondary byproduct of a public health measure. So then that leads to the question, are these public health reductions actually enough to improve public health? Is this a meaningful difference in terms of the health impact? So what we did is we set up this sort of hypothetical scenario where air pollution within these 4 cities is reduced long-term, proportional to the reductions that we were seeing during the COVID-19 lockdown. So another way to say this is how would deaths in each city change if current reductions of PM 2.5 were maintained long term? And some of the assumptions we made in this analysis is that indoor air pollution's exposure or to or concentrations of other air pollutants besides PM 2.5 remain the same. And we looked at adults age 30 plus dying from any cause, so all-cause mortality. And you can see here on the left, these are those reductions we saw before in air pollutant concentrations, 41% Lima, et cetera. And you would expect, of course, that cities with the higher reductions in air pollution would see greater health benefits, right, if these levels were maintained long term. And so here in the table on the right, you can see Lima had this 41% reduction in PM, or for Lima, a 41% reduction in long-term PM 2.5 would result in a 7% reduction in the all-cause mortality rate, or the death rate among adults age 30. And this leads to about 2,500 fewer deaths per year. So this is a large impact on health, right? If you have a public health policy that can reduce your mortality by 7%, that's a big impact. And as you would expect, these smaller reduction in Mexico City of 5% led to a change in death rate of about 0.6%. Santiago, 21% reduction, Sao Paulo, 31% reduction in PM 2.5 would lead to about a 3% lower death rate per year if these lower concentrations were maintained long term. So why does this matter? What's the point? Well, ambient air pollution causes about 145,000 deaths in Latin America and the Caribbean every year. This is completely unrelated to COVID. This is 2019, 2018, 2017, et cetera. And it's possible that in a post-COVID world, or as we are transitioning to dealing with the COVID-19 pandemic as a long-term problem, it's possible that there's a return to car-based transit, right? Which actually means that ambient air pollution in urban areas could actually go up as a result. But we're also seeing that these air pollution concentrations can become lower with public health policy, can be reduced, and that it's not inevitable that they remain so high. And so as economies in Latin America and really across the world, but as these cities start to reopen and suspend these lockdowns, it's a really critical opportunity to rethink or take a fresh look at policies and structural changes that can keep these air pollution reductions, that can maintain them long term, which really would have quite a large impact, not only on mortality and death, but on chronic diseases and health equity issues. Thank you.
Great. Thank you so much, Josiah. Great presentation. And it's fine if you leave that slide up, as everyone will know that we are on the question and answer session. So thanks for everyone sending your questions. Please continue to do so. You can do that in English, in Spanish, or in Portuguese, and we will do our best to go ahead and address them. So we're aggregating them to make the process more efficient. And I guess what we'll do is go back to the beginning. There's a number of questions for Nelson. And Nelson, let's begin with one that I will package under measurement. And it has to do with comparisons between the measures that you use, the satellite-based measures, and ground level sensors, some of those that precisely Josiah used. Have you seen that? And related to it, what happens in some regions, like in Brazil, one of the questions suggests that there is such a sparse network of sensors that you don't really understand a lot of the variation over space and over time. And the last question around measurement, so I'm packaging three of them, is whether we do have enough spatial resolution to be able to do sub-city comparisons by socio-demographic characteristics, or whether it was necessary to aggregate to a broader level to be able to do this analysis, or whether there was a different way of doing it that was possible.
Okay, so I'll try to answer all three at the same time. Let's see. I mean, the use of satellite information, satellite readings is getting a trend now. It's getting more common. Exactly because we don't have monitoring stations everywhere, and satellite readings are. I mean, they are all the time reading air pollution. So it's a very powerful source of information that we are using now. Those readings, I mean, they are not exactly reading exactly the pollution from the satellite. I mean, those readings are transformed. I mean, there are quite a lot of mathematical equations to transform those readings into the actual levels. The levels I've shown in this presentation, and they are also, you know, weighted by the urbanization in some areas. They are weighted by the monitoring readings in some where we have the monitoring stations. So I mean, they are comparable in the sense that, I mean, to get the estimates from the satellite, you're using all the information from the satellite, but also, you know, of land use, of monitoring stations. So you're incorporating that information to the satellite measurement to get that estimates. We did some comparison of the satellite estimates with the actual measurements in some cities, and they correlate quite well. In general, what we found, the monitoring stations have a bit higher levels than we get on the satellites. That's one thing. The other thing is in terms of, like the Amazon in Brazil. I mean, we have usually monitoring stations only in large cities or those very industrialized. So, and they are placing those monitoring stations in areas where they are suspecting they have more pollution. That's why they place those monitoring stations there. And for, you know, countries like Brazil, which is a very huge area, the whole Amazon is completely uncovered, not completely, but it's mostly uncovered by monitoring stations. So the use of satellites is quite important. But there are other instruments, other devices that have been placed in areas in the Amazon to get, you know, information from that specific region. In terms of the aggregation at the subsidy area, well, subsidy is the smallest level of aggregation that we have so far in SALURBA'L. We're going to have even a lower level, neighborhood level, but subsidy we believe is quite okay, because we for some cities, I mean, we had the measurements by satellite is for a 1 by 1 kilometer grid, and that is a relatively very small area. So for every L2, we have at least several data, several points, that blue dots I showed in my slide. So we have quite a lot of information at the subsidy level. So we believe that that information is okay, because some of the city level are quite large areas. Of course, we also average the L2s into L1s, the city to the sub-city, or better, the sub-city to the city level. So we also have that information. But the information at the sub-city is quite, I believe is okay, because it's quite, I mean, it's based on quite a lot of that data points. Is there anything else that I miss, Daniel?
Oh, Nelson, thank you. That's a very helpful answer. Let me turn to Anna right now. So Anna, interesting technical question. Did you adjust for seasonality in the analysis? And this is relevant because there seems to be much more variance in pollution within a year than across years. And for pregnancy or death during the first years of life, thinking about seasons might be particularly important.
Yes, that's really a good comment and appreciation of the analysis. Yeah, we couldn't adjust for seasonality because we have a limitation of the data, of the mortality data. So the mortality data we have per year, and some monthly death by month of death, it's not available in most of the countries. But we are looking forward to have in some countries the detailed data, and perhaps would be for some less inclusive analysis, but more in detail, going more in depth. with less countries and fewer cities to try to further explore, seasonality, because also infant mortality has seasonality by itself. Respiratory infections are more during the winter time, and so on. And so I think it's a really important confounder, but we were not able to consider that in this study, because it will limit the amount of cities that we could include in the study.
Great, thank you, Anna. And I'll continue my trend of asking about methods in this first round of questions, and then we'll go to broader questions. But I want to stick with methods with Josiah. Again, a couple of questions related to the methods behind the estimation of the effects of air pollution reductions on mortality. So can you explain a little bit more about those? And I'll bundle another question, because there have been many asked about this. Do you think that through those methods, these reductions might be obscuring potential increases in mortality because of COVID-19? For example, if mortality goes down to air pollution, are we underestimating COVID-19 mortality as we're looking at excess mortality to estimate COVID-19 deaths? Are we underestimating as a result?
Yeah, sure. So for the estimation of the impacts on mortality from the long-term concentrations, I'd be happy to talk more later about really dig into the technical aspects. But we used established methods based on the World Health Organization methods, similar to the AirQ Plus tool from the World Health Organization. And so really we assumed this long-term ambient PM2.5 exposure, so not focusing on short-term changes, but really talking about years at a time. And we assumed a log linear response, which is sort of the default or very normal for what you would expect in this situation. Because that relationship between air pollution exposure and death is not exactly linear. You see these greater improvements in health along the lower range of reductions in air pollution. So in terms of for the underlying population data, we used data collected by SALURBA'Ls from government sources to establish the baseline mortality rates and the underlying population characteristics for each city. In terms of the impact of COVID on mortality long-term, that is absolutely true and absolutely valid. And from the beginning, we were very specific about trying to focus on non-COVID-19 deaths. And also really just setting up this hypothetical scenario in order to illustrate the impact that these lower concentrations could have. We're not necessarily predicting that everything, that we can control all factors in the future when we're getting these estimates, but holding everything constant for what it is today in terms of the underlying population, in terms of these other pollutant concentrations. If we just maintain these reductions in PM2.5, these are the improvements in mortality that we would expect.
Thanks, Josiah. Let me turn to Nelson again, going round robin again. Nelson, there is a question about the social demographic associations you found, with some countries showing older adults more exposed to unhealthy particulate matter levels, and other countries the opposite, right? Younger populations were more exposed. And so one of our participants is asking, what do you think are some of those factors that explain those differences across countries, and cities within countries as well?
Okay, yeah, I mean, we can only speculate about that because we didn't collect any, data in local data. What I believe, I mean, what we can speculate is that people were, I mean, in the case, I think it's Colombia, we have sort of a younger population more exposed. What I think is that younger population are living, or population living in polluted areas are younger than populations living in other areas that are not that polluted. But why is this happening? I don't know. I mean, we can only speculate. Perhaps those areas more polluted is where we have, I don't know, industries or jobs. So that's why younger people are living around there, and that's why they are more exposed. But I mean, we can only speculate, as I said.
Thanks, Nelson. And I'm thinking about the longitudinal nature of your data that makes, I think, your analysis particularly interesting because it's not cross-sectional. Can you tell us a little bit more about what you found relative to maybe thresholds and how much variation was there in pollution, both over time and across cities?
Do you hear me? Yes.
Yeah.
Yes. So what we found that is on average the annual. So the average of annual means over the 6-year period was 12 micrograms per cubic meter over the whole sample. And particularly most of the cities, as mentioned, as Nelson was mentioning, in Chile and in Mexico were towards the highest quartiles of air pollution. The idea of applying that's in terms of thresholds, right? The annual thresholds that the World Health Organization set as 10 as a cutoff. But what we've seen is that independently of the thresholds, it's also seen that even in cities with lower levels of PM 2.5, each increase in the levels of PM 2.5, independently of the threshold, will be associated with changes in mortality or increasing changes in mortality among under 5 and infant mortality. So the idea of applying this kind of longitudinal approach, which we call hybrid mixed methods, it's that independent. So once you got repeated measures by years within cities, and also within sub-city units, you are considering the changes over time in the exposure, how they are linked to the changes in the outcomes, independently of the time frame, and also independently of thresholds. This implies that even in small cities, an increase will also imply a change in mortality. I don't know if I explain this correctly or you have further question.
Yeah, thank you, Anna. And I'll leave it for those of you that have been asking questions to follow up. That's also perfectly fine so that we can engage in the conversation. So there's that chance also to continue reiterating a question or asking a follow-up. Josiah, I wanted to bring the discussion to other sources of air pollution. So Nelson in his slides identified the various potential sources from traffic to stationary sources to farming and blowing sand and volcanoes, et cetera, that he highlighted. It seems that in Latin America, there's also agricultural fires, or what we see here about in Brazil, the burning of the rainforest in order to create space for cattle grazing or agricultural activity. And there's also indoor air quality concerns, mostly through heating and cooking sources. So I wanted you to reflect with us on how is that reflected in the current analysis, if at all, and what are some sort of complementary policies that could help address, for example, sources of indoor air pollution that are also quite important and might explain, for example, how Chile is so high up in some of the figures that Nelson provided.
Yes, great question. So when you think about, when you study urban air pollution or outdoor air pollution, usually what you're doing is you're using a satellite or some sort of ground monitor to make an estimate of what the outdoor air pollution concentrations are at a person's home of residence. But that is not necessarily very well correlated with what their true personal exposure is, right? So you can imagine somebody who's a smoker inside their home might have an actual real exposure to air pollution, which is much higher than their next door neighbor who doesn't smoke within their home, right? And so, but at the same time, we do see that across a population, these outdoor concentrations are enough to really elicit a major health impact. And a lot of that is through the outdoor air coming into the inside. So within Latin American cities, in a lot of rural parts of Latin America, there's cooking is a major source of indoor air pollution. Cooking with biomass cook stoves, which is a huge global problem. Though in Latin America over the last few decades, that has really started to trend down. Similarly, smoking has started to trend up in many places in Latin America over the last decade or so. And so that could be sort of, that could be increasing the exposure for a lot of people. So as you mentioned, a major source of indoor air pollution is cooking. Gas stoves can produce some higher concentrations of indoor air pollution than we would like to see. And there are some programs, like in the country of Ecuador, for example, where they're trying to transition people to electric stoves. And that can really be a way to build health equity, because people who have sort of lower means as a household tend to have dirtier stoves, or tend to cook or see a worse ventilation in their homes, compared to people who tend to be wealthier, who tend to have cleaner stoves. And so there are a lot of health equity promoting policies that can happen to address indoor air pollution within the region as well.
Thank you, Josiah. Going back to Nelson, curbing fossil fuels seems to be an essential strategy for addressing city vehicular pollution. Nelson, do you have any examples or illustrations of green and clean energy for transportation that other cities can look into?
Yes, I mean, there are several alternatives to. I mean, in Brazil, in particular, we have alcohol, which has been used as a fuel for transport, which is, I mean, it's not that it doesn't pollute, but it's a bit better. I mean, it has other types of pollutants than petrol, than fossil fuels. And then we have electricity cars, and then, which are, everybody knows they are, spreading all over now, and they are, of course, much better, much cleaner than the traditional engines. So there are several possibilities of, using clean energy for transportation, either by electricity, natural gas, and alcohol. Ethanol can, I don't know if it can be considered a clean energy, because I mean, there is always environmental impacts on all energy use, even electricity for transportation. Okay, the car on the streets is not polluting at all, but to produce that electricity, you might be polluting somewhere else. So there is always a trade-off. So instead of clean energy, perhaps we should think on active transportation, just cycling and walking, that doesn't use any type of fuel at all.
Nelson, and let me just build on that, because it really follows on another related question. Given the high levels of pollution that you identified for some cities, and this potential for bicycling or active transportation to address pollution levels, yet at the margin, if we start encouraging people to walk or bike in these sort of highly polluted environments, it could be counterproductive. So how to position active transportation as healthy right now, as we're kind of maybe turning the corner, given these high levels of pollution?
Yeah, this is a very important question. It always come up in talks about like this, because it's a trade-off. I mean, if I'm cycling, I'm contributing to have less air pollution, but if I'm cycling, I'm more exposed to air pollution at the same time, because I'm cycling and I'm having a higher breath rate. But I mean, there are studies trying to show that cycling or walking, they also are beneficial for our health in terms of physical activity. And there are some studies already showing that, the trade-off between the health impacts of exposure to air pollution are sort of balanced by the benefits that you have by doing the exercise. So far, I mean, I don't think there is a clear answer for this, but so far what I've seen, at least in the literature, shows that there is still some sort of benefit in terms of walking or cycling that are could be even higher if you're cycling or walking in a clean environment. But even if it's not that clean, I mean, you still get some benefit by the exercise you're doing. So perhaps that's the message that you can provide in terms of selling the active transportation as a mode of transport.
Thank you, Nelson. Anna, I wanted to ask a broader question about the sample. And there's a couple of our participants have asked, how did you include or how did you select the 371 cities overall for SALURBA'L? And more specifically in your study, I noticed that you were not using the 371 cities, that you used a slightly smaller sample. So can you walk us through the selection of kind of the big sample of cities, and then why was it reduced, and what are some of the data challenges around these concerns that led you in this direction?
Yes, Daniel, thank you for that question. Yeah, I haven't mentioned that or I passed that very quickly, but yeah, we used 337 out of the 371 because we were including cities that were having data on air pollution and in under 5 mortality available for over all the 6 years period. And as I was explaining before, the most constraints are related to retrieving mortality data, at least also among this group, for all the countries and all the cities for all those years. And so the selection criteria, it's basically we took from all the cities included in SALURBA'L of 100,000 inhabitants or more, those who were having infant mortality, that means at under 5 death and infant death and child death, as well as live birth available for the whole 6-year period.
Okay, thank you. Thank you, Anna. Josiah, let me ask a question about your specific estimates for some of the cities. So it seems that Mexico City reductions were kind of the smallest, around 5% compared to 20, 40% in other cities. The question is whether it's possible that higher temperatures, maybe a drier climate, kind of some of the environmental contextual conditions in Mexico City played a role in explaining that smaller estimates. And more broadly, do you think that the estimates could differ by the type of pollutant that you are considering? So you showed us some NOx or some NO2, you showed us PM 2.5s, and that's where most of your analysis happened. Could it be different for them or other pollutants like ozone, for example?
Yes. So first of all, about Mexico City, it was kind of there was a bit of attention that was given. There were some news articles about the fact that Mexico City did not see these reductions, while many other cities did. And I think most of that probably comes down to kind of bad luck in terms of climate factors, in terms of the weather at that given time, that were preventing Mexico City from seeing these other reductions. There were also some certain factories and other very important, very major sources of pollution in Mexico City, which continued to operate at the same levels and continue to contribute pollution. And that ties in nicely with the second question about different kinds of pollutants, because there are 5, 6, even more major air pollutants, which we tend to look at first when we're thinking about health. And they're sometimes correlated, but not always very correlated. And they also often come from different sources, right? So NO2 or NOx is very strongly correlated with vehicle traffic, diesel exhaust, things like that, whereas PM 2.5 can often come in from a much larger distance much further away, and can also be probably more closely linked to, say, coal-fired power plants, other sort of major industrial processes. And so we would absolutely expect that these would not necessarily be very well correlated, especially with these lockdown orders that are having these kind of unexpected, unplanned effects And so you would expect absolutely that if you looked at different pollutants, you would see perhaps different patterns that would not necessarily correlate with PM 2.5.
Thanks, Josiah. I know we have only 5 minutes left, and I really wanted to take this next round of questions. And if you can answer them briefly, that would be great. But I wanted to think about policy and reflect a little bit about kind of next steps. Nelson, you identified some city characteristics that were associated with higher or lower levels of PM 2.5. What would be your message to a decision maker in terms of what could be done to address air pollution at the city level?
Well, I mean, there are quite a lot of messages. I mean, I think the first one would be, well, don't put emphasis on motorization, on cars and vehicles for especially individual cars for transport. Try to have better public transport so people can change from their private cars to public transport, especially if public transport is use green energy, such as, you know, electricity, like subway, metros, and or other clean energy. Enforce more, you know, encourage people to use more bikes and walking. And there are also the ways, you know, the ways you build up the city, the ways you regulate the use of the land in the city that might help, you know, avoiding having sort of air pollution hotspots. So there are several, I mean, not only on this project in SALURBA'Ls, but in the literature in general, you can have several, you know, examples of interventions that can be beneficial in terms of having a better and clean air. You know, having more green space, increasing the amount of green in a city would also help.
Thank you, Nelson. And I would add one parenthesis there. Santiago, Chile has done a great job in turning over its bus fleet towards electric. And it's until a couple of years ago, at least, it was the second largest public transportation fleet that is electric. So it's an example worth understanding. Some of the explanations are specific to Chile, but again, something to think about for the region. Anna, nobody wants to kill babies. And so it seems to me that your analysis just has so much punch to mobilize decision makers and the public. Is this a possibility, you think?
Yes, well, yeah, I think that was, as I was mentioning during my presentation, I think the message that we convey with this research is that the importance of, I mean, for any stakeholder, policymaker in any city, I think reducing death, particularly among under 5 and infant population, it's one of the top priorities. And seeing that with these evidences that, you know, air pollution, it's also impacting on these levels of mortality among this population, which is vulnerable and also has implications over the life course, economic implications as well. I think this is a very strong argument to support changes for environmental policies, and we are not closely demonstrating any, as Nelson research, any characteristics of cities related to levels of air pollution, but knowing that this has an important implication on a certain group of you know, population, and in the population, it's a very strong argument, I think, to also support other evidences towards environmental policies.
Yeah, great opportunity. And last question, Josiah. It looks like cities are reopening now. So how can we shape a post-COVID reopening of cities to address precisely the problems of air pollution that we've heard today? Are we going down a lane in which we're repeating history and we're going to be saying, I told you so? Or what can we do differently?
Yeah, that's a great question. In many places, it seems like we are repeating history, but I think a lot of the things that Nelson mentioned, you know, are especially important. There have been a lot of situations where cities have tried to encourage social distancing by closing down roads, by increasing bike lanes. And that can also have good impacts on air pollution as well. So I think, throughout this pandemic, public health has taken a firm priority over the economy in many ways around the world. And I think 145,000 deaths by air pollution in Latin America and the Caribbean is an enormous number of deaths. Yeah. And perhaps the lessons that we are learning about the importance of public health and sort of can help us reevaluate this balance, perhaps, or it's not a balance because it's not a conflict, but in terms of really keeping a central focus on public health while building cities that are more equitable.
Great. Great, Josiah. Thank you. Well, again, we are on the hour. Thank you for attending the webinar. A special thanks to Dr. Gouveia, to Dr. Ortigoza, Dr. Kephart for their time and presentations. For all of you panelists that were listening, that were asking questions, thank you very much for your time. I hope that this was a worthwhile opportunity for you. We will be making the recording available to all of you. And in fact, we are hoping to be recording the same webinar in Spanish so that it will be more broadly accessible to the region. Do follow us in social media at LAC Urban Health and also via Twitter. So our website is in the chat box that has been sent by Andrea and Claire. Thanks everyone, and until the next opportunity. Bye.